board bombs.
We're on air. We're live.
We're on. Are we live? Are we live?
Yeah, we're live.
All right. Great,
Let's go.
Great. Hey, it's good to be back, Briggs. We've had like a crazy last month. I had like Ramadan stuff. You had Easter things. It was just a busy month.
Exactly.
Busy
I was in
month for
Utah, hiking
Yeah.
and camping as well.
You were in Utah. I was at certain basketball games as well.
Yes.
Put that hat on real
God.
quick. I'm putting this over my headphones. It looks kind of awkward.
Yeah, it does.
For those who
Pretty.
can see the
pack.
pack.
The
NC State.
You guys had a good run.
Pack. We had a great run.
You heard it here first, ladies and gentlemen. On the board bombs, we predicted NC State.
We predicted this.
We did though. What we both actually did say they would make it past the Elite Eight.
Right? Yeah, we were like, man, they're gonna make a run, and it was great to be on that ride. I ended up going to the Elite Eight and the Final Four, took my kiddo, and it was a heck of an experience. I was out in Arizona, Dallas, so shout out, fun times. Hey,
Absolutely.
You know what's not as fun? This next topic we're going to talk about.
Also, you know what's not as fun is if you're listening to the podcast and you're not on YouTube, you didn't see his baseball cap.
Yeah, that's true. Yeah,
We're going to keep
really
you guessing. So
hop
log on to the YouTubes and check it out.
to see NC State will pack represent.
But yeah, this is not going to be exciting.
It's not.
Yeah.
It's not
fun.
We're going to get through it, though, because this is a topic that's listed for ABIM, and honestly, it's something that you should know. You're not going to run into it.
How could you follow up last week, honestly? How could you go from mushrooms to... Yeah.
And not just that, I will, I know you like to say I don't give you credit, and, you do, you're always like, just jonesing for credits and stuff, and I will give you credit. That was one of the best solo pods that you've done. The puns were just amazing. They were absolutely stellar. Just if you haven't listened to it, you just need to listen to it back. Listen to that again. I'll say it. So
yeah, maybe. And on a happy note, other than
kudos, good sir, for
a
fantastic episode.
Thank you. I'd like to give credit to my family for this honor, as well as my.
Going into the question,
yes.
A 45-year-old female presents to the emergency department with an acute onset of severe abdominal pain, nausea, and profound weakness. Her husband reports that she's been increasingly fatigued over the last few months. She's unfortunately lost a significant amount of weight. They don't know exactly how much. Her medical history is significant for a pituitary surgery performed 2 years ago due to a non-functioning adenoma. Her blood pressure is 90/60, and her heart rate is 110.
Cowabunga.
When you ask her and her family kind of her medication list, they give you a pill box that has no actual pill bottles. It just has all her pills listed Monday through Sunday. And you ask for the names of the medications. They look incredulously at you and ask you, then they look at your name tag to see if you're an actual physician. And their next question is, what med school did you go to? This did actually happen to Dr. Briggs, where they were expecting him to be able to readily identify every single
through forensics. Yeah.
Oh, that's good. That's good. Hey, but we digress. Hey, which of the following is the most appropriate initial management in this patient, Dr. Briggs? Is it A, administer a bolus of LR and start stress dose corticosteroids? Is it B, perform a CT scan of the abdomen with IV contrast? Is it C, give antiemetics, IV bolus of LR, and start the patient on IV vasoactive agents to increase blood pressure? Or D, provide analgesia and observe in the emergency department? What's the correct answer, Dr. Briggs?
Correct answer here is going to be choice A, administer a bolus of LR and start stress dose corticosteroids.
There you go. And this is one
of
those.
That's all you need to know. Let's log off.
That's all you need. We're done. We're done. Hey, shout out to EM News, our only sponsor, the only one we allow on EM Board Bombs. Again, don't reach out to us, other folks who are interested in sponsorships.
Don't come knocking.
The easiest ones to say no to are the. Anyways, I'm not going to say it.
I was wondering what you were going to say.
Yeah, EM News. I'm not going to say it. EM News, though, seriously, shout out. We love them. The newsletter is great. They always have been supportive of us, and we've done a step with them before. before. Great articles. And then obviously a shout out to EM Rapid Bombs. It's pretty straightforward. Go to emboardbombs.com. On there, you'll see the sign-up page for EM Rapid Bombs. You can also access it on emrapidbombs.supercast.com, but you can access it through our main website as well. If you want really short podcast episodes, more than 400 episodes now. We're probably going to hit past 500 at the end of this year, which is pretty awesome. We've got a bunch of residencies who've signed up as well. So if your residency class is interested, feel free to reach out. Especially, we've got a decent number of requests post ITE. I think some folks got the scores back, and residencies reached out.
Trying to study a little bit.
Yeah, we need to maybe bump up those scores. But we're happy to provide residency plans, and it's always awesome to see people all over the world using EM Rapid Bombs, that premium podcast, from med students to residents to seasoned attendings. But hey, let's get into this one. Ooh, what are we talking about here? It's not the sexiest
Exciting
topic,
stuff.
but you know what? ABEM has it listed as a topic to know on their compendium. So you got to know it.
Along with
You gotta
everything
know
else.
it. Along with everything else. I know. But this is literally listed under it's got a specific topic. So this presentation, with severe abdominal pain, nausea, weakness, hypotension, tachycardia, combined with this history of pituitary surgery, it's going to be raising immediate concern for acute adrenal deficiency secondary to the topic that they want you to know, panhypopituitarism.
Also called PHP. I'm just kidding.
I think there are a lot of things called PHP.
Yeah.
Hey, so basically, this condition, you have inadequate secretion of multiple pituitary hormones. It's going to include ACTH. I'm not going to even get into what that. Should I get? Okay. All right. So adrenal corticotrophic hormone, leading to secondary adrenal insufficiency. So the loss of ACTH prevents the adrenal glands from producing sufficient cortisol, which is vital for the stress response. Metabolism and fluid electrolyte balance. So that's really, really thinking about it, that's the only main way that this is going to be asked on a board question, and even in the ED, not making that diagnosis very early on in the non-acute phase isn't necessarily going to kill that patient. And frankly, you're not ordering a lot of the tests required to make that diagnosis. But in the acute setting, being able to glean from that history that we provided, what is actually going to help, especially those stress dose steroids, is absolutely critical as the EM provider. So talk a little bit more about the pituitary.
Yeah, so I don't know if you knew this, but the pituitary gland plays an important role in hormone secretion. And here at Briggs University School of Medicine, we like to we teach you about all these hormones. But that isn't a 300 level class. This is a 100 level class.
This is 100 level class.
So we're just going to tell you.
We're going to tell you what you need to know. I know. Man, honestly, do you remember those diagrams in med school of all the feedback loops and just everything coming from
it wasn't.
I
I hate to sound like a complete nerd. I know dear listeners probably don't think that at all about us.
Yeah, you were probably
me,
great at
or
it.
me.
You were probably great at it.
But I was about to say, I really enjoyed actually this section because to me it was very much just like physics. It was like an electrical feedback loop. You had negative feedback loop, positive feedback loop.
Sure.
So I hate to say it actually was enjoyable.
Yeah, great. Good for you. Good for you, Dr. Briggs.
But anyway,
let's get into it.
But I definitely didn't want to go into that field.
Get into it.
God bless the men and women who do endocrinology. We're not going to go into the details of the growth hormone, TSH, LH, FSH, ACTH, prolactin, et cetera, whatever.
Nope. This is not the podcast.
This is not the podcast.
This is not. It's like, what does the Jedi say? This is not the podcast. If you can see me on the YouTube,
you have to wave your hand.
Yeah, you gotta wave your hand.
Like Qui-Gon Jinn. Yeah,
this is not for you.
Anyway, sorry for the Star Wars reference. Anyway, just continuing our nerd theme here. So just understand that hypopituitarism is a medical condition characterized by one or more of these hormones I just mentioned.
Yep.
That's not going to be produced by the pituitary hormone. Now, what's the most common cause of this? What's the most common cause of a panhypopituitarism issue where it's more than one hormone? Yeah. Well, easily it's going to be some type of tumor or adenoma. The predominant cause are these adenomas, which account for about 60% of the cases or so. Yeah. And these tumors could cause an overproduction of a single hormone, but the vast majority of these adenomas are actually non-functional. They just grow, they're there, they're just, fibrous tissue, whatever, and they affect all the downstream effects of, pituitary hormone production. Every now and then you'll get something, as we all remember, probably is the one we probably remember, is that prolactinoma, right?
Oh, yeah.
The one that produces prolactin. But again, we're not getting into the details of that in particular. And for the record, don't start ordering prolactin levels on
my God. No.
patients that come in with breast tenderness. Instead, you should probably just get a pregnancy test.
Yeah. It's probably much higher yield. Yeah.
I remember a med student asked me that one time. I had a young female come in, and she had breast tenderness and some abdominal cramping. Yeah. And he's like, "Are you going to get a prolactin level?" And I said, "No, I'm going to get a pregnancy test."
Pregnancy test.
And it was positive. Anyway.
A urine pregnancy test.
Yeah. Surprise, surprise. Anyway. So anyway, these tumors can overproduce a hormone. They can be non-functional. It doesn't matter. And for instance, one example is acromegaly, a very classic endocrine med school tested condition. That's from an excess of growth hormone. Yep. And that coincides with hypopituitarism due to this macroadenoma, and it's producing growth hormone. Just one example, along with the prolactinomas. But again, nothing is particular here you have to really know about. The most common situation, Dr. Hussein is exactly correct, is that these patients are going to come in and they're going to be essentially in this stress state because of the lack of downstream adrenal hormones or steroids, same thing.
Right.
So hypopituitarism is associated with many different tumors. We're not going to list them. I was going to ask Dr. Hussein to pronounce them, but before the podcast, he pronounced them all so successfully that it's not even funny anymore. It's not funny to hear him try to pronounce them.
I know. I've gotten really good at this. I've got hats off to my teachers in kindergarten through second grade. English as a second language. ESL. Thank you.
Yeah. So there's no point even listing them. And anyway, in addition to tumors, though, what are other causes of hypopituitarism? Well, one really common one would be traumatic brain injury, unfortunately. Another would be iatrogenic injury during some type of surgeries, some type of irradiation due to cancer therapy, whatever.
Sure.
All those things can cause it. Yep. And moving on here, since we got the causes sorted down, we brushed them aside. The physical exam. What is the physical exam going to show you? Well, nothing important. None of this stuff's really going to be yielding here. The presentation of hypopituitarism is usually very subtle. It's these non-specific hormonal symptoms over time. So the only thing you have going for you, as you said at the beginning of this podcast, is the vital signs. And if the vital signs are normal, you very well might miss this presentation, and they're either going to come back to the ED with much worse vital signs, or they're going to follow up with their primary care doctor, and hopefully he or she will do an excellent job working this up, and that's okay. That's where it should be worked out.
There's key things that we talk about, like this isn't a patient on. These patients oftentimes will be put on chronic steroid therapy, but the way you might be tested on is that they have not started those steroids already, and they'll give you that background of increasing fatigue,
tan skin,
and weight loss. Exactly, these kind of generalized things have been going on for a time before then, and acutely their symptoms getting worse due to some sort of acute illness.
And we have covered that before. We have covered specifically adrenal crisis on this podcast before. It's also multiple episodes on the rapid bomb. So again, if you're a rapid bomb subscriber, you have heard us talk this to death. In fact, I think you did the podcast on the expected electrolytes you would see in adrenal crisis. So check that out, and you'll get all the information. Okay, so let's summarize here the different target hormone conditions, what you would see presentation-wise, just really briefly. The first one is, I would say, the most obvious one we all maybe see more than others is hypothyroidism in isolation and associated with hypopituitarism. So obviously we know hypothyroidism. We think, low metabolic rate. We think obesity. We think weight gain, dry, coarse skin, especially hair thinning around the eyebrows, alopecia. We all know that. Great. We already covered adrenal insufficiency. We hinted at that. We covered the hypotension part, the fatigue part, the vital sign abnormalities. We've covered the electrolyte abnormalities again, which we're not going to cover again. That was on rapid bomb, so just check that out. Why don't you cover the last couple here, the last target hormones, hypogonadism?
Sure.
I even said the word for you.
Thank you very much. Yes. Thank you. So, in men, you're talking about this can manifesting as small and atrophied testes, whereas in females, it can lead to a loss of axillary and pubic hair. Neurological and ophthalmological involvement, you're looking at this can result in a loss of certain types of just visual acuity, extraocular paresis, and bitemporal hemianopsia. That's the one everyone loves.
Yeah, that's such a buzzword.
Hemianopsia. That's a huge buzzword for like something going on in the adrenals, right?
Which crazy? Sorry to interrupt you. I specifically remember this med student in question. That is the question that they may be hinting at with the adenomas, right? And that adenoma grows to a certain thing, and it pushes on the optic chiasm.
Oh yeah.
And I know it sounds nerdy, but I'm telling you, the easiest thing on the test is going to say, "Oh yeah, they stepped out they feel like they're stepping out into traffic on the crosswalk because they can't see the peripheral vision, or they can't drive well. They're missing people turning into their lane or something." So it's so classic for a pituitary adenoma. Just remember that.
Bitemporal hemianopsia. It's huge buzzword. Big buzzword. I love it when my
That's
residents use that
code.
word. Yeah, when my residents will be like, the patient does not, doctor is saying the patient did not have bitemporal hemianopsia. I'm like, I see what you're trying to do there. Another one, diabetes symptoms including hypernatremia, polyuria, again, not the sexiest stuff that we're talking about here, right? Let's just get into the summary. Let's bring it together for the social. What is this, Briggs? Just summarize everything we just talked about.
Yeah, so it's really important you recognize this when the patient is really sick in front of you.
Yeah.
And that's what's taking a good history, getting their med list.
Yeah.
And if you're seeing that they're on steroids at home, or if you're seeing they have a history of some endocrine issues and they're hypotensive, tachycardic in the ED, you need to be really, really on it of giving high-dose, stress-dose steroids.
There you go. Because vasoactive agents, like we mentioned in the answer choices,
they're not going to work.
They're not going to work. Right?
No.
They're not going to achieve what you're looking for, and you're going to start chasing things like sepsis and cardiogenic shock and a bunch of other stuff. Where if you'd just gotten that history of fatigue, weight loss, any sort of post-pituitary surgery, those are all critical things to understand that person is going to need stress dose steroids, and they're going to need them fast. So that's absolutely critical to recognize in this case.
Absolutely.
Hey, Dr. Briggs, that's pretty much it for us. Hey, that was fun. We got through a tough topic. And emrapidbombs.supercast.com. You can also subscribe by going to emrapidbombs.com and then finding our Question Bank podcast there. More than 400 episodes now and going. And that's pretty much it.
Looking forward to it.
We have some big plans coming this summer. So be on the lookout for that.
For the next adventure.
It's going to be fun. I won't embarrass Dr. Briggs yet, but I will at some point.
Can't wait.
Yeah. A huge camping trip, but with a twist. Dun, dun, dun. With a twist. See you, Briggs. Bye.